Welcome to the Ottobock Experts on Demand Education Series. This is a previously recorded webinar presented by Executive Medical Director Dr. Andreas Kannenberg, Director of Professional and Clinical Services Mark Edwards, and Director of Reimbursement Services Kimberly Hanson. In this course, our instructors will discuss the functional and technical design differences between the C-Leg and Kenevo microprocessor knees, as well as a number of clinical criteria to guide selection of the MPK best suited for an individual patient. In addition, the course will also discuss the specific reimbursement challenges for MPK for the K2 user population. This course is approved by ABC for 1.25 CEU credits. Please note that in order to receive credit, you are required to take the quiz and pass with a minimum score of 80%. The quiz link can be found on our Experts on Demand webpage or in the YouTube video description below. Enjoy the webinar.
All right, so good morning or good afternoon, everyone, and welcome to our Experts on Demand webinar, C-Leg and Kenevo, the functional differences and reimbursement guidance. My name is Andreas Kannenberg, and I'm the Executive Medical Director for North America. My co-presenters today are Mark Edwards and Kimberly Hanson, but I'm going to start the presentation. What I would like to do first is to take a look at the evidence for benefits of microprocessor-controlled knees in K2 patients that have already been established. Yet coverage is still lacking. So the payers and especially Medicare, CMS have told us that they find the evidence to be not sufficient to make policy decisions yet. So we will have to do more studies to convince them. But I think when we take a look at the available evidence that is available currently, there are a lot of good arguments to think about using microprocessor knees, not only in K3 and K4 patients, but also in K2 patients. Because the studies that have been done in K2 patients have found that use of microprocessor knees can reduce falls by up to 80%. They also improve the risk of falling and the balance confidence and the indicators for the risk of falling. Patients can walk 14 to 25% faster on level ground when they walk with a microprocessor knee as compared to a non-microprocessor knee. They may be able to negotiate uneven terrain 20% faster than with a non-microprocessor knee. They may be able to descend a slope 30% faster with a microprocessor knee and also have improved or demonstrate improved quality of stair descent. Studies have also found improved performance in activities of community ambulation. About 50% of the K2 patients that have been enrolled in microprocessor knee studies were able to improve their mobility level to K3. Which is a really good sign. Studies have also found improved indoor ADL performance, so especially around self-care and being able to live an independent lifestyle. And as far as preference is concerned, more than 90% of the patients that were enrolled in microprocessor knee studies in the end preferred the microprocessor knee over their previous mechanical knee. So there was a recent change in coding of the Kenevo. Originally, the Kenevo was launched with a recommendation for billing the L5858, that is microprocessor stance control only, together with L5828, that is hydraulic swing and stance control, L5845, which is stance knee flexion, L5848, which is stance extension dampening, and L5850, which is swing extension support. Then we made the experience, we actually applied for the change of the language in the C-brace code. We wanted the HCPCS work group to add the stumble recovery as one of the important features to the L2006 C-brace code, but the HCPCS work group denied that request and said that from their perspective, stumble recovery is part of microprocessor swing control. So that meant that although Kenevo doesn't provide microprocessor controlled swing adaptation to variable cadence and walking speed, similar to the CLEC, or at least in a narrower speed range, that the stumble recovery feature that Kenevo has qualifies it for the L5856. So we applied to PDAC, and sure enough, we got the verification for L5856, L5828, L5845, and L5848. We're still appealing the denial of the L5850. So as the Kenevo is now built with the same codes as the CLEC, that raises the question how to distinguish candidates, patient candidates, for the Kenevo and for the CLEC. So who is better served with the CLEC and which patient is better served with the Kenevo? So let me just take a look at the functional options with the Kenevo. The Kenevo has 3 or 3.5 modes that can be adjusted in the software. There is mode A, mode B and B+, and mode C. In mode A, the knee is locked for the whole stance phase and swing phase. So it behaves like a locked knee. There is no stumble recovery feature, and doesn't need to be because the knee is locked. And of course, there's no intuitive stance function because the knee is locked all the time. So this mode is usually used for patients immediately after an amputation for the first mobilization, that you put the patient on a prosthesis, that they're able to walk with a locked prosthesis, and then you can increase the functionality over time. Next mode, mode B and B+. In mode B, the knee is still locked during the stance phase. In mode B+, it allows for up to 10 degrees stance flexion, and the knee is free during the swing phase, and it provides swing adaptation to variable cadence and walking speeds between 0 and 3 kilometers an hour. With mode B and B+, we also have the stumble recovery plus feature. So the stumble recovery in the Kenevo is a little different from that in the CLEC because it works over the whole swing phase, including the swing flexion, the heel rise, whereas with the CLEC, it only works during the extension movement. So from heel rise, as soon as the shank starts the extension movement, then the stumble recovery of the CLEC is active. In Kenevo, it is active over the whole swing phase, including the heel rise. What Kenevo offers in all modes is a sitting down support and a passive standing up support. I'll get back to that in a minute, and also a wheelchair function, and Mark will allude to that in his presentation a little more. And then we have the yielding mode, the mode C. There we have height dampening stance phase and a free swing phase. And Kenevo also offers the stumble recovery plus feature and the intuitive stance function. Once the patient uses mode C, here it becomes really important to think about, is the patient better served with the Kenevo in mode C or with the CLEC 4? Because the function of the Kenevo in mode C is pretty close to what the function of the old compact was. And those patients usually are low K3 patients, and they may be better served with the CLEC. And it takes a little bit of thinking and weighing the pros and cons of both knees against each other for the individual patient. So Kenevo offers 3 modes. Mode A, the locked mode for rehab indoor activities, usually used, for instance, in Germany, where Kenevo is meanwhile kind of standard of care for the rehab after amputation. So it is the first knee that the patients with above knee amputation receive. It is used in the locked mode for the first mobilization then, and as soon as the patient improves the function, the function of the knee joint can be increased over time to mode B, B+, and C. So in mode B and B+, that's the typical K2 patient, probably So mainly walking indoors, but a little bit outdoors. And then in mode C, that enables also a lot of outdoor activities. But as I said earlier, a patient who uses Kenevo in mode C, that takes some thinking and weighing of the options to determine whether the patient is better served with the Kenevo or the ceiling 4. So when we look at the indications of the two microprocessor controlled knees, then we can say CELAC 4 is clearly a knee for patients at K3 and K4 level, whereas Kenevo has been developed for K2s and also low K3s. So, and of course, these sub-classifications of low, mid, high, K2 or K3, they're not official, and they're also highly subjective. But I think it is useful to say that the Kenevo is not the need for the typical mid or high K3 patient, because the Kenevo can't keep up with the functional needs of these patients. So if a patient presents with difficulty sitting down, that is clearly an indication for the Kenevo. Also, if the patient has challenges to manage the standing up from a seated position in one movement, then that is a consideration for the selection of the Kenevo, and I come back to that here on the next slide. So when we look at the resistance that a hydraulic knee produces, the typical hydraulic knee, and here the black curve represents the resistance curve for the CELAC. So when a patient stands in front of a chair and wants to sit down on the chair with the weight loaded on both legs, the prosthetic and the sound limb, then the hydraulic produces high resistance first, but once you've made the flexion movement and the flexion progresses, then the resistance of the hydraulic usually diminishes, and the patient needs to balance the body on the sound limb to sit down on the surface of the chair in a smooth manner. That is something that K2 patients usually can do, or they struggle with it. So that's why the resistance that the hydraulic of the Kenevo produces is more adapted to the needs of K2 patients. So it holds a long or high resistance for a longer period of time and enables the patients to sit down smoothly on the chair with both limbs fully loaded. For getting up, as I said, the Kenevo offers a passive standing up support that the CELAC doesn't offer. So when the patient wants to get up from a seated position and the knee reaches a flexion angle of 45 degrees, if the patient isn't able to complete that movement in one stroke, then the Kenevo locks and prevents the patient from sinking down back in the chair, and that gives them a couple of seconds to reposition the foot of the sound limb, to reposition the trunk, and to complete the getting up or standing up movement. So with the CELAC, in that case, the patient would sink back in the chair. So, but if the patient is not able to complete or to redirect the foot and the trunk after a couple of seconds, then the patient would also slowly sink back in the chair, but they have a couple of seconds to reposition the foot, reposition the trunk, and to complete the standing up movement with the Kenevo. And for many of these patients, that's really very helpful. Another big difference between the CELAC and the Kenevo is the swing initiation. So with the CELAC, what you do is you adjust the fixed threshold for swing of axial loading for the swing initiation. And that is the reason why patients who walk with an irregular gait pattern or with shuffling steps sometimes don't reach that threshold, because the axial load that goes through the knee is not big enough to reach that fixed threshold. So in K3 and K4 patients, that's usually not the problem because they walk briskly and usually reach that threshold to initiate swing. But for patients who walk with short steps, with shuffling steps, or who use additional walking aids like a walker or a crutch or crutches even, so they usually have issues to consistently reach that fixed threshold. That is why the Kenevo in modes B and B plus, not in mode C. Mode C is very similar to the swing initiation in the CLEC, but in mode B and B plus, the microprocessor of the Kenevo monitors the actual loading for every single step and determines the peak of the actual loading for every single step. And once the actual loading declines, swing is initiated when the actual loading reaches 90% of the peak value for that step. So when the actual loading is reduced 10% below the peak, then the swing phase is initiated. And there is no fixed threshold because that is determined for the actual loading of every single step, and that makes sure that in mode B and B plus, swing is initiated at every single step, no matter how shuffling the step is, how short the step is, how much weight is put on the knee, because every single step is analyzed by the microprocessor individually. So when we look at further indications, patients who need additional support at late stance, these are clear candidates for the Kenevo in mode B and B plus because the swing initiation compared to the CLEC and the Kenevo with mode B and B plus is usually a little delayed, so that gives the patients some additional support and safety in the late stance phase. Patients who walk with irregular gait pattern, especially when they use walking aids, these are also clear candidates for the Kenevo in mode B and B plus rather than for the CLEC. The CLEC or the Kenevo may also be an option for a low K3 patient who feels that the CLEC is a little bit too heavy. So the Kenevo is substantially lighter than a CLEC. So if the patient feels the CLEC is too heavy, then the patients usually walk slower and they walk less outside of the house. So, and I think these patients are probably good candidates for a Kenevo rather than for a CLEC. Also, I already mentioned that the speed adaptation and cadence adaptation in the Kenevo is good for a speed up to 3 kilometers an hour, so that equals 0.8 meters per second. If the patient walks slower than 0.8 meters per second, and that is something that you can test in the 10-meter walk test or 20-foot walk, for instance, then the patient is a candidate for the Kenevo. If the patient walks faster than 0.8 meters per second or 3 kilometers per hour, then the Kenevo usually can't keep up with the patient, and the CLEC is clearly the better choice unless there are other factors that speak for the Kenevo and against the CLEC. Also, a recommendation, if the daily outside walking distance is up to a half mile, the patient may be better served with a Kenevo. If the outside daily walking distance is more than a half mile, then the patient is clearly a candidate for the CLEC. So what are the two patient groups that we have in mind for the Kenevo? Both are lower mobility patients with a need for increased safety. So the first group of patients is patients who used to be clear K3 patients and who have used microprocessor knees usually for years, 5 years, 10 years, or even longer, but who are now aging, declining in health and function, and slowly but surely transitioning to K2. So in these patients, it would be almost unethical to convert them to a non-microprocessor knee because they are used to the safety that a microprocessor knee provides, especially to this, they're used to the stumble recovery function, and they rely on it. And a non-microprocessor knee doesn't offer any kind of stumble recovery. Also, they're used to walking with a microprocessor knee that is very similar to what we do when we walk. When we walk, we ride into our quadriceps muscle. We rely on our quadriceps muscle to stabilize the knee. And that is what patients do when they walk with a microprocessor knee. So they ride into the knee and they rely on the microprocessor control of the hydraulic unit to stabilize the knee and prevent it from collapsing. So in that patient group, it would be unacceptable, if not unethical, to have these aging patients relearn walking with a non-microprocessor knee, where they usually have a need for knee stabilization with untimely and unphysiological hip extension in the stance phase. So these patients always have to stabilize the knee with hip extension during mid to late stance to prevent the knee from collapsing. And if a patient has been used to riding into the knee with a microprocessor knee for years, then it doesn't make any sense to have them relearn to walk with a non-microprocessor knee when they're 70 or 75 or even older. I think that is a patient group where even the medical directors of the DME MACs know that there is a challenge and that there is an issue. And I think they're open for a discussion to keep these patients on microprocessor knees, even if they're no longer classified as K3 patients. The second patient group that is a candidate for Kenevo are mid to high K2 patients who currently use a non-microprocessor knee, usually a polycentric knee or weight-activated brake knee, and have a history of falling and or challenges to their daily mobility needs. So what we have to keep in mind is that non-microprocessor knees usually have a reciprocal relationship between safety and function. So the safer a knee is, the less function it supports, and vice versa. So the more functional a knee is, the less safe it is. So a non-microprocessor hydraulic knee, for instance, supports a lot of function similar to a microprocessor knee, but it is much less safe because the patients need to have much more residual function, much more coordination and muscle strength to stabilize a non-microprocessor hydraulic knee and to prevent it from collapsing. Things that are done by the microprocessor in a microprocessor knee, so the patient doesn't have to care about that. So, and here the situation is what we have to keep in mind also is that reciprocal gait on non-level surfaces or terrains is only possible with a knee that allows for unlimited stance flexion and yielding. So a knee that uses a hydraulic for stance control. And as I said, you can do everything you can do with a microprocessor knee, also with a non-microprocessor hydraulic knee, but at the cost of reduced safety. So you can give a MAUC, for instance, only to a patient who has enough strength and coordination to stabilize the knee or knows how to fall without hurting himself. So that is very important here. So in those patients who use a non-microprocessor knee and have a history of falling, the argument would be to add the stumble recovery feature or stumble recovery plus rather in the Kenevo for increased safety. Patients who have mobility challenges need a knee that allows for more function but not reduced safety. And that is the trade-off. When you increase the function with a non-microprocessor knee, you have to pay the price in terms of reduced safety, but a microprocessor knee is the way out of that dilemma to increase the function of the patient for their daily lives without sacrificing safety. All right, and with that, I give the floor to Mark to talk a little bit more about the technical and functional details and the differences between CELEC and Kenevo.
Great. Thank you, Dr. Kannenberg. And good afternoon, good morning to all of you. I see a lot of familiar names on the attendee list, and this morning I'm going to discuss a little bit more and reiterate some of the things that Dr. Kannenberg talked about, but make sure that you as a clinician understand the differences between CELEG and Kenevo. And truly, we now have a knee that can meet the needs of the individual. So Dr. Kannenberg, if you can advance the next slide. So the Kenevo has really technology that is much different than the CELEG. And so we're going to talk a little bit about how this technology and the rule sets within the technology of the microprocessor and the sensor technology that is in the Kenevo can function for the particular patient population that we're trying to fit with this device. Next slide. So how does the Kenevo function? As Dr. Kannenberg was talking about, it is 3 knees in one. So you have the ability of programming the knee into different functional modes or activity modes, such as the lock knee, the semi-lock knee, which is B or B+, and the yielding knee joint, which is mode C. And then in the background, all these basic functions are available to the user. And so it really helps us identify the type of user that can benefit from these functional capabilities of the knee itself. Next slide. One of the things that make the Kenevo unique when comparing it to the CELEG, as Dr. Kannenberg had talked about, was that sitting down and standing up function that is available within the Kenevo in all 3 of the modes. So you have the capability of controlling the sitting down feature, so increasing that resistance as the angle gets greater, and then that passive standing up assist, which doesn't allow the knee to collapse once that individual reaches that 45-degree knee flexion angle, but still have the capability of lowering them down into the chair if they so choose. So here I'm going to show you a video of an individual using the sitting down function in the A mode. So in this particular case, the knee was locked and she doesn't even use the knee, but when the knee is in a fully extended position, after a couple seconds, it releases. And then you can see in the standing up position that she goes to get to the 45 and then it will lock. And then sitting down, she can lower herself down into the chair. And that becomes really important for individuals that are going to go from a mobility device such as a wheelchair and then transition into a walker. So they go into that transition period between pushing off from the wheelchair itself and then lifting their arms off the wheelchair and grabbing onto the walker. And so in that moment of time, they are unstable. The Kenevo provides that momentary stability for them to have that flexion block after they've reached that 45-degree angle. Next slide, Dr. Kannenberg. And a neat feature in the Kenevo is that it has what's called a wheelchair function. The individual can position the knee in a slightly flexed position and it will stay there so that their caregiver can push them in the wheelchair and they don't have to use their contralateral or their sound leg to lift it off the ground as their caregiver is pushing them. Really nice feature and easy to manipulate by the user. Next slide, Dr. Kannenberg. And then in the C mode, we have the ability of the standing function. So here you can see a comparative video of a single axis stance control knee versus the Kenevo, and the individual standing on a bent knee, and it has that intuitive stance feature built into it, whereas the weight-activated stance control knee becomes unstable for that user. And you can see how they have to look down on the ground, where on the Kenevo they can stand on that one leg and it is in that lock position for them. So very nice feature for those individuals that progress to that mode C. Next slide, Dr. Kannenberg. And then certainly Dr. Kannenberg talked a little bit about the Stumble Recovery Plus. So now we not only have the capability of having increased resistance in swing phase in case of a fall in the extension motion, but also in the flexion motion also. So this truly becomes a feature that allows that individual to feel stable and more confident in using this prosthesis. So this really identifies or distinguishes between what the Kenevo can do versus what the C-leg can do in a stumble. And next slide, Dr. Kannenberg. And here we have mode A. So this is a truly locked knee. So the individual goes from a locked position, from a sitting position to a fully locked knee. So very good for gait training, shifting weight, learning with an assisted device, getting confidence and shifting their weight onto that prosthesis. And then they can come back to the chair and they don't have to pull on a cable or worry about that knee not releasing on them when they go to a seated position. The knee knows that they're going to sit down and releases for them. Then as they progress, next slide, Dr. Kannenberg, we can move into the mode B plus. So now it will be locked in stance phase and release in swing phase. And the difference between mode B and B plus is that the knee in the B plus mode will allow for 10 degrees of stance flexion to occur and then block that 10 degrees. So it's not a yielding knee. It goes to 10 degrees of flexion and then blocks it. So the individual can get used to walking with stance flexion. It also helps them going down shallow ramps with this mode. So this is great to train a user. And this is where Dr. Kannenberg was really distinguishing between the functional capabilities of the C-leg versus the Kenevo in mode B and B plus, especially walking with a walker, because that threshold of meeting the highest point of load, because the Kenevo has a load cell in it, and it can sense when that individual is in the late part of the gait cycle, whatever step they're taking, and release the knee at the appropriate time. So it's not looking for the typical tilting forward, moving forward knee extension moment that the C-leg is looking for, and looking for that on every step. So this is measuring each step individually and then accommodating it for that individual. Next slide, Dr. Kannenberg. And then mode C, as that individual begins to progress in their rehab and get more confident in using the knee, this is where you really have to make the determination, do you need a Kenevo for this individual or a C-leg? So Dr. Kannenberg laid out nicely the individuals that are transitioning down from a C-leg. They're getting older, they've been using a C-leg for 20 years, but they don't need all the functionality of it, and they walk at a slower speed. So this might be a good mode for them to use. And then those individuals who truly do walk at a slower speed, walk outside for less than a half a mile, those types of individuals, the Kenevo would be a good fit for them. Next slide, Dr. Kannenberg. So really, you have an opportunity now to have a knee that really fits that potential K3. They're a K2 now, but they have the potential to move to a K3, or they're that low K3 individual. So you can program it in mode A, where they can't control the swinging knee joint. They walk with assisted devices. They do most of their activities within the house, but they need stability and be able to sit in the chair, rise up from the chair, and be stable. The mode B, they can go outside, walk probably with an assisted device, and utilize stance flexion in mode B plus. And then mode C, they walk with alternating steps, controls swing flexion during swing phase. They can walk with a yielding knee downstairs, down ramps, and you truly now have a solution for these individuals that we tried to fit with the C-leg before, but probably that was too much knee for them. So this knee really provides them with the capabilities for the activities and functions that they need. Next slide, Dr. Kannenberg. So this just gives you a little comparison about the differences between the Kenevo and the C-leg. And if you advance one more, we'll focus in on the Kenevo. So as we say here, the indication that K2, low K3, up to about 1.9 miles per hour. It has the stance control in both sitting down and standing up, that stumble recovery, the sitting function, the donning function, and so forth. And then when you look at the C leg, next advance, you can see that they walk at a much faster speed. They have that yielding resistance. The stumble recovery is only occurring in the swing extension phase. So once the heel meets its maximum heel rise, that then it kicks in, whereas the Kenevo is kicking in both the flexion range and the extension range. It doesn't have the capability of lowering them down into the chair or having that functional standing up function that the Kenevo does. So it really truly is for that true K3 level of patient. So hopefully that gives you a better idea of the functionality of the Kenevo compared to the C-leg. And now I'll turn it over to Kimberly, and she'll talk a little bit about coding and coverage.
Great. Thank you, Mark. Appreciate it. So looking at the coding, I know Dr. Kannenberg covered it, but just wanted to show you all of 4 of our microprocessor knee joints that have the coding, the new Kenevo coding, C-leg, and the G-Name X3, we still maintain the L5999 code for. Next. So let's talk a little bit about coverage. So all 4 of the microprocessor knee codes are restricted to K3, K4 for Medicare, or with the potential to achieve K3 status within a given time frame. So in theory, the potential K2 patient to achieve K3, but Medicare would then classify him for billing as a K3 patient. Private payers do also accept the potential as well. We've had a lot of questions regarding that and wanted to be sure that we called it out. With the new prior auth program with Medicare, I recommend if you have a patient with potential for K3 and you're fitting either knee joint Kenevo or C-leg, that you demonstrate the ability for them to ambulate, their desire and motivation to ambulate, and send that through your prior auth process and get the feedback at the prior auth process. I think previously we've always had the plan of care patient was a potential for K3, but we waited to fit them or submit it to Medicare as a potential for K3 until they went through additional therapy and such. But we are seeing more approvals now based on a plan of care for upcoming events and have that patient do all of that therapy and activity in the microprocessor knee joint. So we're seeing good success with that. Next, please. So I wanted to show you, often questions is, are there any payers out in the country that cover K2 MPK? There are about 19 payers in the country, but I really wanted to call out this national policy. It's not in every state. It's in about half of the states right now for Blue Cross Blue Shield, and they have talked about having K2 limited community ambulators be medically necessary for microprocessor knee joints, but only if improved stability and stance permits, increased independence, less risk of falls, and potential to advance to a less restrictive walking device. So when you are evaluating your patient, be sure you go look at the Blue Cross Blue Shield plan in your state, because you may have some opportunity in this category. So you wouldn't actually have to demonstrate that they have the potential to be K3, meeting the definition of the K3 ambulator, but really talk about the items that the reason you would actually fit a patient of a K2 in a microprocessor knee joint or in the Kenevo for this improved safety and stability. Just wanted to call that out to you so you knew that was available. There are the other language in the Blue Cross Blue Shield plan is in the next slide, please. So most other Blue Cross Blue Shield plans will look to cover microprocessor knees for the long distance ambulator at variable rates, demonstrate the need for regular ambulation on uneven terrain, and really kind of keeps you in that K3, K4 category. But I did want to show you the differences. The Blue Cross Blue Shield Association had picked up that K2 level language, and we are seeing it being adopted across many states. So if you have questions as you come across a Blue Cross patient, need help pulling policy, feel free to give the reimbursement department a call at Ottobock. We'd be happy to help you find that. Next, please. Another big payer in the marketplace is Anthem, and we are seeing that Anthem is really kind of sticking to the K3 or above. There are some new criteria that are in there, so if you are fitting a K3 patient, you want to be sure that your physician notes discuss adequate cardiovascular reserve and cognitive ability. That typically would be in the physician notes. And then there is this prior effective use of microprocessor-controlled knees or use of a temporary device when able to complete such a trial. As you know, we have trials available with our sales reps. And so in order for you to help meet your definition, to talk about the discussion if they haven't been on a microprocessor knee, you'd want to reach out to your sales rep to get a microprocessor knee joint in your office so you can demonstrate that trial. Next, please. Additionally, when you talk about the Anthem language, they kept the 400 yards or greater in their language. They also have this multidisciplinary assessment of the individual, so you will want physician notes, therapy notes if you have a PT involved, as well as your notes. So it is multidisciplinary assessment of that level. It does clearly state that K2 or below is not medically necessary, but we have seen some exceptions made to this policy when it went back to improve safety and stability. And we'd be happy to guide you through that through the reimbursement department. So I wanted to give you a visual chart. Don't need to go through all of this, but really looking at documentation requirements between K2 and 3, and then K3. What would the physician require, as well as the physician and prosthetist notes? We are seeing, during documentation reviews of our prosthetist notes, we are seeing a lack of activity related to maintaining that K3 functional status or the potential for K3. So be sure that you get their social activity level. They don't just need the knee joint for golfing, but they do many other things, household chores. They participate in the community, go to church type of activities to really show that the patient is out and about in the community. We are seeing lately a trend of patients at K3 level status and trying to rely more on the physician notes to demonstrate that. And I don't find physician notes are getting to that level of detail. Why you feel like when you're on a K2, increased stability and stance will allow increased independence, and why you believe there's potential for less restrictive mobility aid. That certainly would be something based on the training that the patient would do, the therapy the patient would do, and their motivation to have, let's say, going from a walker to a cane. You would really want to discuss that. Obviously, you can't control the outcome of that because you rely on 100% compliance on the patient to be able to improve that. But you really would talk to the patient about where they want to go in their mobility aid. Next, please. And then for private insurance, you'll definitely want to look at the policy language. And I find that their clinical documentation is for medical necessity, but also meeting the administrative check marks of the medical policy. So you're really going to want to make sure you do both. Why it meets unmet needs or why it's most medically necessary for the patient, but also getting the checkbox around your policy language. Next, please. And then for the medical necessity, we talked about the K level based on activities, current condition, motivation to ambulate, sufficient strength, balance, cognitive ability. We really talk about getting that information from the physician notes. I know many physician notes aren't that level of detail, especially if they aren't maintaining the patient with a recent amputation. But it is something that we have quite a few documents to help you promote getting good physician documentation from them. So, and you will be getting a deliverable at the end of this webinar that has that documentation in there. Next, please. One of the key reasons we're seeing for denials during the prior auth process with Medicare, as well as some other denials, is reason for replacement. Medicare, as well as private insurance, have a pretty strong reason for replacement should be documented. For Medicare, they allow it on the standard written order. So oftentimes, if you're sending off that for a signature to get from a physician for your prescription, if you put the reason for a replacement on there, that would definitely qualify. but you're really going to want to look at functional physical changes, irreparable, unable to be repaired, or the high cost to repair the device. So you'll want to be sure that your reason for replacement is in there, especially if you're replacing same or similar. You're going from one to the next. Why the current device meets their needs, and a lesser device would not be applicable. You'll want to be sure you document that, but also if it's a functional change or physical change in order to demonstrate that, especially if they're going from a K2 to a K3. If a patient is a K3 level ambulator, or you feel like they're a potential K3 level ambulator, and you fit them with a Kenevo, and they end up going leaps and bounds and out walking the knee, and now you need to get a C leg, that is a very difficult conversation to have with any payer saying, I said they were a potential K3, I just picked maybe the wrong product, because we don't want them out walking the K3 knee if they actually become a K3. So you'll want to really consider that in your product selection. Next, please. We have created a new Kenevo guide for you. It's all-inclusive, informative guide based on your NPK selection chart, based on the information that we've provided you today. Features some benefits, as well as the physician documentation guide and checklist. So there's actually checklists in there that you can use to audit your physician notes to see what elements are missing based on the policy language, based on Medicare LCD, in order for you to achieve most success when you're submitting your claim or submitting your documentation for prior auth, as well as the prosthetist documentation guide and checklist. Same cadence. Tells you what you should be putting in your notes, as well as a little checklist for your office managers or coding staff to actually look through it, make sure that your notes meet guideline as well. Wonderful. So I wanted to thank you for your continued support of these monthly webinar series. I hope this is informative.
Thank you for watching this previously recorded Experts on Demand webinar by Ottobock. Please click the link in the video description to access the quiz and submit for continuing education credit. If you have any questions, please contact the education team at 1-800-328-4058 or via email at us.education@ottobock.com.